Good evening and welcome to tonight's Medtronic Diabetes Q&A webinar. Joining us tonight are our two guest speakers, Dr. Thomas Ulahannan and Minimed 640G insulin pump user, Patrick Denham. My name is Dean Kanakis. I'm a part of the Medtronic marketing team here, and I'd just like to take this opportunity, in case you haven't had the chance when you registered to submit a question, you can do that on our Facebook page, that's Medtronic Diabetes Oz, or hashtag for Twitter, 640G webinar. So just to do our introduction, our guest endocrinologist speaker tonight is Dr. Thomas Ulahannan. He was a senior consultant in endocrinology at Gloucestershire Royal Hospital for 12 years in the UK, and is currently working out of Bundaberg Base Hospital, Wide Bay Hospital Health Service, and is also a senior lecturer at the University of Queensland Rural Clinical School. Thank you for joining us tonight, Dr. Ulahannan.
Thank you, Dean, for having me.
Okay, our other guest speaker tonight is Patrick Denham. Patrick has had type 2 diabetes for around 10 years now. He was an officer in charge, or a paramedic, for 43 years in the Queensland Ambulance Service. After 6 years on multiple daily injections, Patrick made the switch to insulin pump therapy. And Patrick has also received a number of awards. He was the recipient of the Australia Day Award, Ambulance Service Medal, and Distinguished Service Medal for Queensland Ambulance Service. Welcome, Patrick.
Hi, Dean, and hello to everybody.
Okay, so to get things kicked off, our first question for you, Patrick. From multiple daily injections to MDI, from multiple daily injections to insulin pump therapy, did you find there was a lifestyle shift? And if so, was it positive or negative?
Well, there was a major lifestyle switch for myself. I'd reached a point where I was unable to do any of my normal functions like mowing the lawn, washing the car without going and having a hypo. My blood sugar level would drop from 14 down to 3 in a matter of 5-10 minutes of doing any exercise. I'm now, since going onto the pump, I now can wash the car, I can mow the lawn. I have control over my bolus and basal, which allows me to modify my doses depending on what my activities are going to be for the day, which means that the control of my diabetes has come back to me rather than having doses prescribed to me regularly by a doctor. When I'm unwell, that's the other advantage, that when you're unwell or you're changing your medications, you can change your basal dose by increasing it or decreasing it to assist you with the changes that are happening in your diabetes. So to me, it's given me control back of my life and control back of my diabetes. And because of the new systems in place, every time I do my blood glucose, every night I download and upload it onto the site so that if ever I have a problem, I can just ring my doctor or my diabetic educator and they can see all my results in front of me because the pump is transmitting that data through the internet. So yes, I find it very positive, and I recommend a pump for better control of all diabetics, whether they're 1, 2, or whatever they are. Yeah.
All right, thank you very much for that, Patrick. So our second question for our endocrinologist speaker, Dr. Ulahannan, how does the pump help reduce long-term complications and the impact of health issues?
Yeah, look, Dean, I think this is a really important question for a lot of people, because people with diabetes want to stay healthy, they want to avoid the complications of diabetes, and the way that they do that is by controlling their blood sugar better, in particular by avoiding low blood sugar, hypoglycemia, which the pump allows you to have more flexibility in administering the insulin. And of course, you know, when you have an insulin injection, you can't untake the injection. With an insulin pump, even after you have commenced the bolus delivery of insulin, you can adjust the rate, which is one of the key factors in how you're able to deliver that insulin better to your needs. So avoidance of hypoglycemia is a big benefit. But another long-term benefit is avoidance of high blood sugar, hyperglycemia, and we know that people with insulin pump therapy who are trained properly and who make use of extra skills like carbohydrate counting can, in the long run, improve their glucose control, their glycemic control, and that helps them to avoid those feared complications like eye damage and kidney damage and nerve damage, which is called neuropathy. So these are important benefits for people, which the pump is a useful tool to help people along that way.
Great, thank you very much for that, Dr. Ulahannan. Just a quick reminder, if you haven't taken the chance to already submit a question, please do so on our Facebook page or on our Twitter account. Okay, our next question for you, Patrick. Having the pump attached to you at all times, do you find it prevents you from living a more active lifestyle?
No, Dean, I find it's you don't even know you've got it most of the time with all the new belts and pouches and attachments or accessories you can buy, depending on whatever activity you're doing. There's an accessory that you can use. If you go to the gym, there's a special Velcro band you can use for that. When you go to bed of a night time, you attach your Velcro pouch, and the only time is if you want to go swimming, you can get up and you can insert your cannula into your buttocks, in the top of your buttocks, and when you're going to go swimming, you can either leave your pump on or you can disconnect it, put the plug in, and go out and swim, and nobody knows you've got it on. Nobody knows you've had a pump. You can adjust it. So, if anything, I think that with the growing awareness of diabetes and the number of people who do use pumps now, I think that lifestyle doesn't change at all. I think that there's a greater understanding of all ages, from primary school children through to the older generation now, about diabetes and insulin pumps. The only thing we have to do is teach them that type 2, because you've got an insulin pump, doesn't mean you're a type 1 diabetic. That's the only back thing from it. Yeah, I've found that's hard to explain to people, the difference between type 1 and type 2. Yeah.
Okay, thank you very much for that, Patrick. Second question for you, Dr. Ulahannan. Two-parter. For people moving from MDI to the pump, what do you find are the most common concerns? And once on the pump, do you find these concerns persist?
Well, again, I think that's a really relevant topic. I think there's a couple of common concerns that people have. One of them, first of all, is the fact that they're going to have something attached to their body. They're going to have a device attached there, which is going to be present 24 hours a day, basically. And if you compare that to insulin injections, once you've had the injection, then obviously the insulin is inside your body. There's nothing attached on you. So that is a big worry for a lot of people, kind of connected to the previous question we heard there about, will it affect my life? Will it affect my appearance? Will I be able to wear normal clothes? Another common problem that people, or worry that people have, is am I going to be able to operate this device? Is it going to be too technical for me? Do I have to program it? You know, is it like a computer or something like this? And again, you know, this is something that when people actually come down to it, they find that they can overcome it. In terms of the attachment issue, there really are a number of different ways that you can have the pump carried on the body, in terms of different pouches, in terms of different belt devices. For ladies who are concerned about being able to dress fashionably or smartly, again, there are lots of different ways in which a pump can be worn or concealed. And again, once people try these things out, they find that they can use their imagination and solve that. Again, with respect to the pump programming, I often say to people that if you can manage to work a mobile phone, if you can send a text message, then you can operate the basics of a pump. Now, there are a lot of sophisticated features which you can learn about, but when it comes down to the real basic of delivering a bolus, of setting a basal rate, then I believe that the great majority of people can achieve that. So I find that a lot of these concerns, these common concerns, they really evaporate once people go through some proper training with somebody who can help them and guide them.
Thank you very much for that, Dr. Ulahannan. Another question for you, Patrick, around lifestyle. Do you find the pump uncomfortable when going to bed?
No, I don't even. Well, I've got to the point where I forget that I've got it. It isn't an issue because you have it in a pouch on a Velcro belt, and the only thing that you know about it of a night time is because I'm on a continuous glucose monitor as well, because I was having a number of lows, especially during the early hours of the morning. So with my monitor, it talks to my pump and tells me, my pump, that I'm having a low, sets off an alarm, and the only thing I had to get used to was this alarm telling me I was going to have a low shortly, hop up and go and treat it. And I think I sleep better now, and I know my wife does, because she was always worried I was going to have a hypo in my sleep of a night time, and that she'd wake up and find me in a hypoglycemic coma. So wearing it is no issue when you stop and think of the benefits you're getting from it and your management during the night when you're asleep.
Right. Thank you very much for that, Patrick. Dr. Ulahannan, another question for you. I've used injections for years and I don't see any need to change. Is there really any benefit with the pump over injections?
Yeah, again, this is something that you hear a lot from people, and you can actually sympathize with that view. You know, you can understand people have the view that if something ain't broke, you know, why fix it? But in fact, when you just dig a little bit deeper, you often find that actually people are having some problems there which they've almost begun to accept. I mean, a very common problem is people who are suffering hypoglycemia when they go out to exercise. Maybe they're going out to mow the yard, or they're doing some yard work, and before they know it, the blood sugar has dropped. And this can happen for a number of reasons. And the problem with hypoglycemia is that if you keep on having it, you actually start to lose your warnings, and this is a very dangerous situation. This is called hypoglycemia unawareness. And you know, many people feel absolutely fine, but they're actually in a dangerous situation because the blood sugar could get lower and lower before they feel any symptoms. And if they were operating a vehicle or up a ladder or something, that could be really dangerous. So that's one thing that may be happening to people. And Patrick has mentioned the continuous glucose monitoring technology, which is a very good way to pick up hypoglycemia, even, you know, when the patient is asleep and obviously can't check his own blood sugar. And that can often reveal that there are quite a lot of problems there which, you know, in all good faith, the patient didn't even know about. So that's one thing. I think the other thing is that when you look at people who are on very high insulin doses or who are needing to constantly bolus many times in order to keep their blood sugar under control, and they feel that in a way that they're always on a kind of merry-go-round where they're constantly chasing their diabetes. They're having to take boluses, they're making adjustments, the sugar isn't quite right, they're doing a correction, and it just goes on and on and on. And again, for somebody like that, an insulin pump with the ability to set different basal rates and ability to have different kinds of bolus, delayed bolus, all these kind of facilities, it may just be that little magic key that helps them. I say magic, but it's not really magic. It's actually to do with training and finding the right tool for your needs. So I think that I would say to somebody who's having these kind of problems, you know, think about it, keep an open mind, and you might be surprised that actually things that you have been putting up with for a long time could actually be helped.
Great, thank you very much for that. So just another reminder, guys, any questions you want to submit while we're live, please do so by hashtagging 640G webinar on Twitter or reaching out to us via our Facebook page, Medtronic Diabetes Australia. Okay, Patrick, a question for you. What was your HbA1c before and after starting insulin pump therapy, and do you feel you could have achieved this through MDI?
No, my HbA1c was between 10 and 14, and even with it in that range, I used to have an average of 3 to 4 hypos per week, and when they really got bad, I was getting 2 to 3 glucagon injections to fix my hypos, and then after I was given the injection, I'd be taken off to hospital. I could never have achieved that. Got over that without the pump. So by going onto the pump and my continuous glucose monitor, what it did was 2 things. One, it improved my glucose to 6 to 7, and my HbA1c to 6 to 7, but it also was able to record what was actually happening to me over a week, a day, 24 hours, 4 weeks. And when I went back to my endocrinologist, because I was on the pump, all this information was downloaded onto the endocrinologist's computer. And they had heaps of data and information, and they were able to go into my pump and do masses of adjustments for different periods of the day. So from this period to that period, I'd be on one setting. So it's not just one continuous setting. The whole system is set up to address a 24-hour diabetes issue, and that can only be done by being on a pump. And if you're have a lot of hypoglycemic episodes or problems, you need to seriously consider going on to continuous glucose monitoring, because it talks directly to your pump, stores all this data, and your doctor can it gives them a larger amount of information to start your treatment. And it gets to the point where they got it so finely tuned, it's like taking your car in for a tune-up. They adjust all your permanent settings, and it's just you have to make adjustments for any extra thing. If you go off-road driving, you turn on your four-wheel drive or something like that. So the pump is like having a computer hooked on your hip. And the other thing it does is it keeps the patient honest. I found that you get up and you give yourself some insulin and you'd say, oh, I ate too many carbs, so I won't actually record that in my little book. Whereas with a pump, you actually can't hide that, because when you administer insulin to yourself, then the doctor says, well, how come you're giving your insulin but you had no carb intake? And it's a massive advancement in teaching the patient to manage their diabetes and accept responsibility for it at the same time. I hope that helps. I just can't speak too highly of the pump. And what I've got to say is I've had 2 pumps. This is my second pump, and the 640G model is phenomenal, because it does a lot more than what it allows my sensor and my pump to talk to each other and to warn me of my lows and to take action and cut off my insulin, which for a person who used to have a number of lows, it's very important. So people who think that they're right, and as the doctor said, they could be having a large number of issues that they know nothing about. And with the pump and with the sensor, you can get an overall total picture of the patient.
Thank you very much for that, Patrick.
Dean, could I just come in, just one little comment there?
Absolutely.
The question there was almost making out that HbA1c is the sort of the truth about diabetes. And I just want to make a comment that HbA1c is an average blood sugar over the previous 3 months. It's an average. So a person who is getting lots of highs and lots of lows can still come out with what appears to be a very good average. But when you drill down and look into their blood sugars, the control is terrible. They are going up and down, and they are going to feel really bad. So what we want is we want ideally, diabetic patients, not to have too many highs, not to have too many lows. And sometimes you actually find that the HbA1c goes up a little bit when a person gets to better control because they're just not hitting hypo. So I think that's just an important thing I want to say there, that HbA1c is not the final God's truth on everything about diabetes. It is a useful thing, yes, definitely, but it hides a lot because it's an average number.
And I can confirm that because that was my case. The reports that came out and what I was actually shown on a graph blew me away. You know, I was heading down a path of massive damage to my nervous system and other issues until I got proper management of my diabetes. Yeah.
Thank you very much for that. Okay, so Dr. Ulahannan, another question for you. What sort of change in HbA1c have you seen from your patients living with type 2 as they continue using pump therapy?
Well, this is it's an interesting question. It's also quite a hard question to answer because people are very different. And I think if you were to look overall at clinical trials and what's an average answer, then I would say that in the best conditions, with proper training, then on average you'd see an HbA1c improvement at somewhere between 0.5 to 1% on HbA1c. That's if you were to take a global average of all patients. Now, if you just break that down a little bit and look at patients who actually were having more problems, people who are having greater difficulties with their diabetes, you very often find that their HbA1c improves a lot more than that. I mean, I think Patrick himself here is an example of somebody who actually was suffering a lot with his diabetes, had a pretty bad HbA1c, and he's had a very big improvement. Now, that is something that you will see in people who, if you like, have the greatest need. But, you know, if we're talking medically about the global average, because don't forget, some people go onto pumps when they're not actually that bad, you know, they may not be that bad. So, of course, their amount of improvement is going to be less. So I think if you were going to take a safe average, something between 0.5 to 1% would be a safe average, but individuals may see much better benefit than that.
Right. Thank you very much for that, Dr. Ulahannan. I'd just like to remind everyone, if you haven't already submitted a question, please feel free to reach out to us through our social media platforms. Okay, our next question for you, Patrick. How much does it cost to run the pump? I've got private health insurance, but I've heard the cost of consumables is a bit out of reach for those living with type 2.
Well, I'm on the NDSS, and under category F, I get my consumables funded by the federal government. Most patients who are type 2 and hard to control and that can apply for that, but what's good is that Medtronic have now put in a grant system where they've got 200 grants available for people who are on private health, who can get their pump through private health. Then they get up and their consumables will be sold to them at the same price I'm paying for them. And I wish it had been around when I first started, but it wasn't. Where they can get boxes of reservoirs and giving sets, and they cost $15 a box through the grant system that's run by Medtronic. So this is a great way for diabetics to try the pump system, get onto it. They can get their pump free through whoever the health fund is, as long as they have hospital cover. They can check and see if they have it. And then the consumables they'll be paying for will be the same price I'm paying, and I get mine subsidised by the government under your grant system. So, and the consumables are nothing. All it is a little cannula in a box, in a packet, and a giving set, a container that keeps your insulin in. So I recommend that if you're having any thoughts of going on a pump, you have private health cover and your health cover covers it, I'd be going to your endocrinologist saying, okay, let's give it a go if you think I need it. The endocrinologist fills in the paperwork, sends it, gives it to you to take to your health fund. You get allocated a nurse educator who will teach you about the pump, and I tell you, they're a godsend. And you just pay for your consumables. So you change your giving set every 3 days, and you change your reservoir every three. I change mine every 3 days, but I fill it every couple of days. So a box of 10, $15, and you multiply, divided by 3 days, or it's not that expensive if you go on the system. You can try the pump. The pump's been paid for by somebody else, and if after 3 months or 6 months you find no improvement, then there's nothing to stop you saying, well, I'll put the pump away and go back to injections. But I'd say anybody who's had a number of issues would never go back. Going back to injections is a nightmare if I ever thought I had to go back to it. Yeah.
Right. Thank you very much for that, Patrick. Dr. Ulahannan, another question for you. With pens, I'm struggling to keep my blood glucose level between 7.5 and 10. Could I achieve better control with the pump?
Okay, well, I think hidden in this question here is a hint that this person has been suffering with low blood sugars and also has been maybe experiencing some high blood sugars as well. So this person may well be having quite a bit of glucose oscillation. There could be quite a number of factors in that. So I think first of all, you've got to take a proper history and make sure that this patient doesn't have any medical diseases which could be causing this, like for instance thyroid diseases or an infection or any other illness. You also find that if patients get prescribed other medications, like for instance steroids like prednisolone, which are used for things like asthma and joint disease, this can really, really put the blood sugar sky high. So first of all, you need to see somebody who is experienced, an endocrinologist, and just make sure that there isn't something going on. So let's say that that's been looked into. We then have to start looking into what's happening here with this person's blood sugar regime. Are they appropriately dosing? Another common tricky problem is where you get a thickening of the fat, which is called lipohypertrophy. So because of many injections over the years, the skin and the fat actually becomes quite tough and hard and lumpy, and as a result the insulin is not absorbed properly. So again, for all of these kind of situations like insulin absorption problems or dosing problems, then having a switch to insulin pump therapy might well be a good move, because we've already discussed the ways in which you can adjust the bolus and the basal. And I think for this person who's asking that question, they need a kind of systematic look over, make sure there isn't anything going on, and if they feel that they can go for it, then yes, I would say under education and supervision, go for a trial on pump therapy.
Thank you very much for that, Dr. Ulahannan. Okay, so for our last question, Patrick, what would be your one piece of advice to someone thinking about making the switch to a pump?
See, get referred to an endocrinologist and be totally assessed. I found that I'd been managed for a number of years by my GP, and it was only when I insisted to be referred to a endocrinologist that I was, and from there my whole life changed, because I suddenly became part of a holistic plan. There was a diabetic educator, there was the endocrinologist, and as a team they looked at all my problems I was having, and they came up with the solution. Because my diabetic educator, by the way, is also a dietitian, so I get 2 for the price of 1. So they looked at the overall management. Large numbers of tests were carried out that found that there were a lot of other imbalances in my bloods, and once they were addressed, then we went to the pump. But I'd say you've got to go to an endocrinologist, talk to them about it, and make sure that your diagnosis and treatment and plan you're on is actually right. And take it from me that if I could get, getting out of giving myself 10 injections a day and going back to putting a cannula in once every 3 days, and the scarring tissue that I used to get from my needles, as the doctor said earlier, I don't get any of that anymore. So don't think about it too hard. Just go to your GP if you're not under an endocrinologist and ask to be referred to one. Yeah.
Okay,
Could I just comment on that, Dean? I just want to say I was really delighted to hear Patrick say the word team, and I think this really is the key to successful pump therapy. Is the team, is the patient, the educator, the endocrinologist, and the manufacturer of the pump. So I think of it as a team. You're not on your own. We're all playing together. We're all here to help you.
Yep.
Thank you very much for that, Dr. Ulahannan. I'd just like to say thank you for everyone who's joined us tonight. And if you have any further questions, please feel free to reach out to us on our 24-hour hotline, 1800 777 808, or you can reach out to us through our Facebook, Instagram, or Twitter accounts. There's also additional information on insulin pump therapy at medtronic-diabetes.com.au, and please feel free to reach out. Thank you, Dr. Ulahannan and Patrick Denham, for joining us tonight.
Thank you.
Thank you.